Hello, I'm John Boyages. I'm the Director of the Westmead Breast Cancer Institute, which is based at Westmead Hospital, which is funding tonight's program called Breast Cancer Challenges After Treatment. Women face many challenges at the completion of their treatment for their breast cancer. There can be unexpected physical and emotional changes, coupled with confusion over follow-up care and, of course, worry about the future. This program will answer many of the frequently asked questions related to those challenges and will offer strategies to assist women in gaining accurate information and to gain access to appropriate support. A list of resources is also available on the Rural Health Education Foundation's website, www.rhef.com.au. For those of you watching the webcast, you can ask questions simply by clicking on the Live Talk tab on the web page you're looking at right now. That also means, of course, that we can ask questions of you. So here's one to get you going. Tell us where you're located. Are you in a metropolitan area, regional, rural, or remote Australia? Now, let's meet our panel. I've asked each of our panel members to speak for 10 minutes about their three most frequently asked questions. Dr. James French is the Head of Breast Surgery at the Westmead Breast Cancer Institute. Welcome, James. Louise Meyer is an occupational therapist with over 19 years of clinical experience in both public and private settings. Welcome. Dr. Tony Hobbs is a rural GP obstetrician in Cootamundra, New South Wales, and he's also chair of the Riverina Division of General Practice and Primary Health. Thank you for coming, Tony. Dr. Nicholas Wilkin is the Director of Medical Oncology at Westmead Hospital. And finally, welcome Nicholas, and finally Professor Judy Kirk is the Director of the Familial Cancer Service at Westmead Hospital. Welcome, Judy. Welcome to all of you. Thanks for giving us your time tonight. And I'd just like to start off by, reminding everybody that breast cancer affects 35 women each and every day in Australia, and a few men, of course. The Westmead Breast Cancer Institute, based at Westmead, has a vision of supporting women with breast cancer today and every day, and is funding tonight's program for free right across this country. We have 5 programs, which includes Managing Breast Screen New South Wales, Sydney West, our clinical care program, research, our education program, which tonight's broadcast is part of, and also our new Ray of Hope fundraising program, which is raising much needed dollars to fund programs such as this. Just a reminder, for women, particularly over the age of 50, those aged 50 to 69, but also any woman over the age of 40, if you have not had breast cancer, please have a mammogram every 2 years by calling 13 20 50 for a free breast screen mammogram. We know that about 3 in 4 women who are diagnosed with breast cancer, this occurs over the age of 50. But it can occur in women much younger than this. And we also know that over 130,000 people are living with a previous diagnosis of breast cancer in this country. And hence, it's really important that we look at challenges after treatment. Too often, we find that the crisis is at the point of diagnosis and treatment, finishing treatment, but then the real challenges occur when treatment is over. Now, I guess I'd like to ask all of our panellists, Judy, what are your top 3 questions?
Well, John, when women are diagnosed with breast cancer, one of the first things they ask is, now that I've been diagnosed, will it make a difference to the risk for my daughter or my sister? So that's the first question that I'm going to address tonight. And the second is that people ask, well, are there some families who've got a genetic tendency to breast cancer? And indeed they are, but they're rare. And finally, people want to know, should I have genetic testing, and how does this genetic testing work? So all of those things I'm hoping to address tonight.
There's some fairly important issues for women, and it's often the first thing that a woman thinks about is her family rather than herself, and
that's
so
exactly
can I
right.
pass it on to my daughter?
That's right.
Nicholas, what about you?
I frequently get asked these days, John, about this 5-year mark. I've got to 5 years, everyone's talked about 5 years, what does that mean and what should I do? So I thought I'd talk about that. Also, there's a lot of women now asking about new alternative drugs to tamoxifen, so I'll talk about that. And lastly, after surgery, radiotherapy, chemotherapy, a lot of women are noticing problems with weight gain and asking me about that, so we'll talk about that as well.
Thanks. Thank you very much. Tony, from a rural general practitioner, what's the key message you'd like to share tonight?
Well, I think there's a couple of things, John. The first is the opportunity for GPs, particularly rural GPs, to be sharing in some of the aftercare for women after they've had their acute treatment for breast cancer. So working in partnership with our specialist colleagues, our surgeons, oncologists, geneticists, occupational therapists. I think that's really important. And of course, that really important role of advocating and working with that woman and her family over that long period of time, because that's a really important role of general practitioners, to have that longitudinal relationship with the woman.
You know, I guess you know the family, often the extended family, you know their social circumstances, and that puts you in a key position to understand what's going on, as opposed perhaps to the specialist who sees them episodically.
Absolutely. I mean, this woman may not only just have breast cancer, for instance, she may well have other very important medical and surgical problems, so it's very important to have a holistic approach to her healthcare. And of course, she may well be part of a family. That's important when we're talking about risks to other family members, and certainly other things such as lifestyle factors and her ongoing care as she ages, particularly around menopause, for instance.
Thank you. Louise, what are your top 3 questions?
Well, John, there's many myths and anecdotal information out there about lymphedema and arm care after breast cancer surgery. So tonight I'd like to talk about what we should do with our arms in rehabilitation after treatment. Also, what do we look out for in regards to lymphedema, and how do I know if I've got lymphedema? And then finally to say, well, how do I get back to normal after finishing our treatment?
Well, they're very important issues, and I guess over the years some of those myths have changed and there's been more and more research coming out, I guess, lately.
There is a lot more recent research out there about lymphedema, and I think for those of us who have had lymphedema in the past, or have had a great aunt or grandmother that's had lymphedema, the surgery is much less extensive these days, and so really we're trying to look at early detection and early management of lymphedema.
That's a good key message. James, what about you?
John, look, I was going to try and perhaps just outline what actually is involved in follow-up. I think a lot of women get caught up in their treatment, and then it's a bit like having a baby. Having the birth is the beginning, and then you've got the whole life of the child. You've now got to follow the woman up for a long time. So I'm going to talk a little bit what's involved in follow-up. And for those women who have had a mastectomy and are now contemplating a reconstruction, I'm going to try perhaps to have a bit of a walk through what we can achieve there surgically and some of the options and outcomes that they can perhaps expect.
Okay, so and follow-up is women like to be followed up because many women are scared, and they get quite scared before they come and see you. And I know tomorrow we've got probably between 60 patients to see in follow-up.
That's right, yeah. Look, I think it is a very anxious time for a lot of women at this sort of anniversary time, and I think often they're very reassured at the end of the consultation, but I think while they're waiting in the waiting room, it can be a very anxious time.
Very anxious time. Well, thank you for coming, and we'd just like to give you the results of our first question, which is tell us where you're located, which is metropolitan areas in 55%, regional 17%, rural 28%, and remote areas 0%. So thank you for everybody who's viewing this public forum, either by webcast or live satellite. Now it gives me great pleasure to introduce our first speaker, Dr. James French, to talk about some of the key questions as a surgeon.
Great, well, thanks, John. Just going to start by saying that breast follow-up. The things I'm going to cover are what is follow-up, how often should you have your follow-up visits, perhaps outline what your doctor might go over with you when you're having a follow-up check-up, and if we've got a bit of time, we might talk about some of the common questions that I get asked. Well, what is follow-up? Well, follow-up is the regular review of patients after they've completed their treatment for breast cancer. And this can be done either by their GP or by their specialist, one of the specialists or a number of the specialists, in fact, in their treating team, or it might be a combination, in fact. And the aim of follow-up really is to try and detect a relapse of cancer early if it's going to happen, and hopefully that won't occur in most cases. It's also aimed at trying to detect any new cancer. So, for example, if a woman's had a cancer in the right breast, it's aimed at trying to detect a cancer in the left breast early. And it's also a great opportunity, I think, for women to answer any of those many unanswered questions. I think as they've come through their treatment, I'm often seeing about a year down the track, they've become adjusted to the fact that they're actually now quite well. And they often now start to bring out the questions which they've probably been ticking away in their mind for over a year, but they've been a bit too afraid to ask. So how often should you be followed up? It's things vary depending on where you are and who you're seeing in terms of your treatment. But the typical sort of protocol that we would follow at Westmead would be seeing your specialist every 6 months for the first 3 years. And that might be alternated between your surgeon or the radiation oncologist if you've been involved with the radiation oncologist, or it may involve your medical oncologist. And at the same time, you probably should be seeing your GP annually as well. Once we get women get out to about 3 years, we tend to think that things are going pretty well, and we drop the follow-up protocols back a little bit, and typically we'd see women annually at that point. And coupled with those reviews, we also get some regular imaging done, and that would normally be a mammogram of both breasts, or one breast if a woman's had a mastectomy. And for those women who've what we consider dense breasts or very difficult to read mammograms, it may get a regular ultrasound. And depending on whether you're on certain medications or whether you develop symptoms, it may involve other medications such as a bone mineral density test or occasionally some more advanced imaging techniques. So what's your doctor going to do in a typical sort of follow-up situation? Well, most of the time your treating doctor will inquire about whether you've got any current problems, whether you've noticed any side effects from medications you're on, whether you've noticed any changes in your breast, whether you've developed a new lump or a thickening or a nipple discharge, sort of things that may indicate the possibility that a new cancer or a cancer is relapsing. Your doctor will inquire about the medications you're on. And then they'll probably perform an examination, and the examination would be to check both your breasts, if you've had a mastectomy, to check the chest wall area, to check under the armpit for lymph glands, to check inspect your arm to see whether you're developing evidence of lymphedema, to check the lymph nodes in your neck. And these are all areas of the body that breast cancer potentially might relapse in, and hence are important to check. And if you've mentioned that you've had pain in an unusual area in your back or your shoulder, or some pain in your tummy, your doctor will also have a careful inspection of that part of your body as well. And usually at the end of a review, if everything looks good, if you've had some imaging that's recent, that'll be reviewed by your doctor. So if you've got a new mammogram or an ultrasound, they'll look at the report and the films. If you're on the alternate visit, say the 6-monthly visit, they'll make sure that those tests are arranged for your next visit. Perhaps one of the most common things I get asked is there anything else that the women ask, is there anything else they can do for themselves to perhaps help decrease the risk of their cancer coming back? And they often ask particularly about diet, and I think there is now some increasingly good evidence that women who are able to stick to a fairly low-fat diet in combination with generally fairly vigorous exercise, typically a 20 or 30 minute a day program 3 times a week where their heart rate's more than 140 beats per minute, can have a decreased risk of their breast cancer relapsing in comparison to women who are very sedentary. So the second thing I was going to talk about tonight, John, really was for those women who were required to have a mastectomy or chose to have a mastectomy as part of their treatment, and for whatever reason declined or didn't want to have a breast reconstruction at the same time, are now contemplating a breast reconstruction. And I think up front I say that there is no right or wrong answer to this, and there's certainly no pressure. Women should certainly feel no pressure to contemplate a reconstruction. I think it's a very, very personal decision as to whether they go through and have one or not. But the reasons that we perhaps talk about reconstruction, and certainly I think it's becoming increasingly popular, is that certainly for large-breasted women, having had a mastectomy renders them often a little bit unbalanced, and they may be developing problems with their back or their neck. I think a lot of women, once they've got through their acute treatment, are now becoming very body conscious. They realise they're well, and they're now starting to take a bit more interest in their self-image. And I think reconstruction is one of the ways we can do to try and regain that. And I think as a consequence of that, they often have an increase in their self-esteem. So I think there's a lot of reasons why women might want to contemplate a breast reconstruction. So what is breast reconstruction? Well, breast reconstruction is an attempt by a surgeon to create what I'd call a breast mound. It's never a new breast. And there are 2 basic methods by which we can do this. The first is an artificial method, and this is typically what we call a two-stage artificial reconstruction. And it's a little bit like breast augmentation that some women might do to enhance their body shape. The other basic way that can be used is to try and borrow some skin fat and or muscle from another part of their body, typically their tummy, and transfer that up to their chest wall to create a new breast. So I'm going to show you a few photos just to perhaps give us some perspective on this. And this first image is just to highlight that there are some women who are actually comfortable or quite accepting of having had a mastectomy and aren't interested in reconstruction. And if that's right for them, that's certainly a very valid option to take. And this is a sort of a typical result, this next photo here, of what could be achieved with a two-stage artificial reconstruction. And we can certainly see this lady in her bra looks well balanced. She's a lady in her mid-30s who is required to have a mastectomy because of extensive disease. And when we take her bra off, in fact, what fills the right-hand half of her chest is an artificial reconstruction. This is a silicone implant put in underneath the muscle and the skin. You might note that she's got a scar on the left breast, and that's a scar as a result of having a breast lift, which has been done to try and bring the native breast or natural breast to match the reconstructed breast. This next lady, once again, you can see in her bra she looks very balanced. Remove her bra and we can see that in fact what fills the left side of her chest on this occasion is once again a silicone-filled prosthesis, and once again she's had a breast lift on the right side. And she's later on this year going to go ahead and have a nipple reconstruction, but at this stage hasn't had that done. I've got another example here of a woman who actually unfortunately had cancer in both breasts and chose to have bilateral mastectomies. And this is an interesting photo because this is her at the end of the first stage of an artificial reconstruction. This is when with what we call the tissue expanders are fully inflated, and you can see they look quite round, a bit abnormal looking, although they look quite symmetrical. But the next image shows her about 3 months down the track having had what we call the stage 2 reconstruction. She's had the expander pulled out and a silicone gel, cohesive gel implant has been put in underneath the muscle, and she's gone on and had nipple reconstructions done. And you could easily imagine that in her bra or her clothing that she'd look very natural and normal, and no one would really be able to tell she'd had an operation. This next photo is of a young girl who I treated earlier this year. She was only 24 at her age of diagnosis, and she's actually had a breast augmentation on the left side, and then you can see on the right side she's actually had a breast reconstruction with a two-stage artificial technique to match her augmented breast, and later on this year she'll have a completion nipple reconstruction. And she was actually an amateur pole dancer, has been able to get back to her pole dancing as well as her professional life. This last example of a two-stage artificial reconstruction is of a young Chinese lady, 35. The breast on the right is an artificial breast, again a cohesive gel implant. She's had a nipple reconstruction. You can still see the scar from the mastectomy running across her chest wall. Now the next example here is a lady who it took 2 years to make her decision about whether she'd have breast reconstruction or not. Again, in her bra she looks reasonably well balanced. When we take her bra off, the breast on the right is in fact the skin, fat and muscle from her tummy that's been brought up to her chest, and she's had, as a result, a tummy tuck, and most of the women find that a bit of a bonus. They quite like that. And she's had the beginnings of a nipple reconstruction done also. So look, that was just a quick run through some of the options that can be available, used in breast reconstructive techniques these days. I just want to highlight or emphasise that it's a very personal choice. There is no right or wrong answers to whether women go through and have this done or not. And any woman who's interested in this should really discuss this initially with their breast surgeon and probably be referred on to a plastic surgeon for further opinion.
Now, we're coming to our second poll question. For those of you with a diagnosis of breast cancer, could you tell us what surgical treatment you've had? Have you had a wide local excision with a sentinel node biopsy, a mastectomy, a wide local excision and an axillary clearance, a mastectomy with an axillary clearance, or no clearance? I'd now like to introduce our second speaker, who is Louise Meyer, who will be talking about lymphedema. And over to you, Louise.
Thanks, John. Tonight I'm really going to look at how should I look after my arm after surgery and treatment for breast cancer, and really trying to reduce the risk of lymphedema and what can we do to manage lymphedema, as well as the long-term coping. How do I get back to that normal life that everybody's telling me I should be able to get back to? So what is lymphedema? Lymphedema is swelling of the arm or chest area that's been affected after breast cancer. It may develop following surgery and or radiotherapy to the lymph nodes under the armpit. But I must stress that most people who have breast cancer surgery will not develop lymphedema. And that is the real key thing. There's many myths out there about lymphedema, but most women will not develop lymphedema. And the latest facts and figures about the incidence of lymphedema is that probably about 20% or less, hopefully, of women who have axillary lymph node dissection may develop lymphedema, and even less than that, about 1 to 2% of women who have only sentinel node dissection only will develop lymphedema. And I must say that I'm not seeing the severe cases of lymphedema that I was years ago because of the less extensive surgery. So hopefully less extensive surgery in that more sentinel node biopsy means less lymphedema and less arm problems after breast cancer surgery, which is really what we're aiming for. With lymphedema, about 70 to 80% of the lymphedemas we see do develop in the first 12 months, but the risk of lymphedema is longer term. So some of the things I'm going to talk about today are really for women to look at long term. So what are the early warning signs of lymphedema? What are the things that we can look out for to start becoming aware of lymphedema? Often, some of the lymphedema symptoms and signs may be quite vague and intermittent. That may include a feeling of heaviness or sometimes some aching or pain or tension in the upper arm, sometimes a tightness or fullness in the arm. And sometimes you may just notice that clothing, sleeves on arm clothes, or sometimes jewellery, watches, bangles, may actually feel a little bit tight. Often early signs of lymphedema is transient. And what I mean by that is that the symptoms may be quite normal of a morning, and after a day of heavy activity or repetitive work, you may notice some symptoms of swelling or symptoms that I've described. So the key for lymphedema is very much early detection. We have a program at Westmead now that we're actually monitoring and measuring women before they even have surgery to look out to try to pick up really early lymphedema so that we're not left with longer term problems. So the key is early detection and early management. So what are some of the things that we do know help to reduce your risk of lymphedema, or things that you can do? I guess the biggest thing that I say to women is use your arm normally as possible, that there shouldn't be any activity that you've done prior to surgery that you can't resume doing after you've finished treatment. Of course, it may take a little bit of time to get back to some of those activities because of the nature of the treatment that you've been through and perhaps not feeling as energetic as what you did before surgery, but certainly we want you to get back to treatment. And I guess with the proviso of becoming in tune and aware of your own body symptoms and picking up any warning signs. So that if you notice that your arm feels a bit heavy or aching when you're doing a particular activity at home or regaining a particular exercise or sport activity, then take a rest when you first notice those symptoms, rather than pushing through and be determined to finish the painting of the wall or the scrubbing of the tiles that you might be doing. Take a rest when you notice the symptoms and see whether the symptoms settle. If they do settle, go back and do those activities, and again in a graded way, so that if you notice any symptoms, you stop and take a rest. So it may actually take you a little bit longer to paint that wall or to clean the bathroom, but hopefully you will be able to achieve it without putting extra demand on your lymphatic system. Also, maintaining a healthy weight is known to reduce lymphedema, and that's probably something we're all going to talk about today, but reducing weight is a risk factor for lymphedema. So trying to reduce weight or at least stabilise your weight is a really good thing to try to do after treatment. Skin care is something that we talk about with lymphedema because of the demands on the lymphatic system, and you may have heard of trying to reduce getting cuts and scratches, burns and bites and breaks to the skin surface. The main reason for that is that the lymphatic system's major role in the body is fighting infection. So if we can take care of our skin and trying to keep it well moisturised, hopefully then we're going to reduce lymphedema. So just getting one scratch or one cut or one burn on a hand does not mean we're going to get lymphedema. It's more so if women get repetitive infections or repetitive bouts of cellulitis in their arm that they may be at a slightly higher risk of getting lymphedema because there's more pressure or demand put on the lymphatic system. So a simple thing that you can do to take care of your skin is using moisturising cream on your arm regularly. And just like you brush your teeth every night before you go to bed, it's a good thing to get into the habit of moisturising your arm. And probably both arms, so that you don't have one really good looking arm and one that's a bit dry. And when you're putting the moisturising cream on, put it on in an upward direction. So rather than going any old direction, try to encourage the lymphatic vessels to drain the fluid in an upward direction. So keeping your skin really well moisturised is really beneficial and doesn't take a lot of time, and we're not saying take a pill for it. Also, regular exercise of your arm will help the pumping and the general circulation of lymph vessels and blood vessels. We see there the dragon boat races, and in the past we might have thought that was very repetitive and strenuous exercise. We now know that women who do dragon boat racing and repetitive weight resistive exercises actually do benefit them in regards to reducing their risk of getting lymphedema and their general fitness as well. So if you're an exercise person, then there is certainly benefit of doing that. Now, I often hear the question about aeroplane travel and should I wear a compression sleeve or not. There is some evidence to show that the lymphatic system is put into increased demand for women who go on an aeroplane, predominantly for long distance travel. And all I suggest is that you talk to your specialist or your lymphedema therapist in regards to whether you're at a high risk or a lower risk of lymphedema, and whether there may be some special precautions you can take when you may go on a long flight. So such things as special exercises or perhaps wearing a compression sleeve may benefit you. If you do develop lymphedema, there is lots of treatment there. And like we've said tonight, early detection and early management is the key to success, but we can treat lymphedema at any stage. And there are qualified lymphedema practitioners all around Australia, and I really suggest that you go and see a therapist to get appropriate treatment. Complex physical therapy is a standard treatment that's known for managing lymphedema, and that includes a combination of these 5 components. So the first area is manual lymphatic drainage, which is a type of massage. Compression therapy, where we may use compression bandages or compression garments or stockings on the arm to try to contain the fluid to maintain the arm size. Skin care, we've mentioned the importance of skin care, moisturising the skin and reducing risks of infection. Exercises, and most importantly the psychosocial management, because we can put on a bra and we can put on a clothing and we can actually hide the fact that we might have had breast cancer to the outside world. But if you put on an arm sleeve and have a large arm, that's visually showing people that, hey, I have lymphedema. And then women have to decide, do I have to tell people that I have lymphedema or that I've had breast cancer? And the psychosocial effects of having lymphedema can be almost as important as the physical effects of managing the condition. So we really try to empower the individual to feel in control of both the physical and the psychosocial factors of managing lymphedema. So another question that I get asked always in my clinic and talk many times with women is, how do I get back to normal after treatment? I guess we call it survivorship after the intensive treatment. And at this time after you finish treatment, there's often mixed emotions. We have relatives and friends all telling us how fantastic it is that we've got our last radiotherapy treatment and we've finished our last chemotherapy treatment. And of course we're pleased and relieved about that, to be finished. But physically totally exhausted often. We still may not have hair on our head, we still may have the side effects of treatment, and the emotional roller coaster ride that we feel at that time is very draining. And sometimes we still have those scared and anxious feelings at that finishing treatment. So although on one hand we might be really pleased, at the other end we've lost our support network of regularly going for treatment and that security that I'm seeing the doctor regularly, or I'm seeing the chemotherapy nurse or the radiation therapist, and so we're let out into the loose, and that can sometimes be more anxiety provoking. So what can we do? I guess I often say to women, we're learning to develop a new normal. So women say to me, get back to normal life now. You can get back to work and taking the kids to school and all the activities that you did before. But life's never going to be exactly normal when we've been through this life-threatening experience and diagnosis of breast cancer. So developing a new normal might actually mean taking time to reprioritise life. Instead of being there always for the children or for work demands or running things around that you might have normally do, learning to say no. is sometimes something that we all need to do in our life, and trying to get a real balance between life for everybody else and life for ourselves. And often women say to me that having breast cancer and going through intensive treatment, although they may have been quite negative and disturbing for the whole family, has actually helped them to reprioritise life and move forward in a positive way. Conserving energy is something that women really sometimes struggle with after treatment, in that they want to get back to doing all their normal activities and they want to be seen as finished treatment and doing all the normal things, but upgrading activities is really important. So be realistic. Slow and steady wins the race. So we see our tortoise there. Let's be slow like the tortoise so that we can gradually get back to all the normal activities we want to. The hare went bull at a gate to try to finish everything, but as we know, the tortoise won the race. So let's be the tortoise, let's communicate our feelings and emotions with others, gain support from family, friends and our health professionals. Perhaps learning relaxation or meditation techniques or yoga, they're all really beneficial for us, and it could be part of this new normal. So gain reassurance from your health professionals and your team. Have your regular follow-up, as James has said to us, and I guess feel empowered to move forward and live life.
Thank you very much, Louise. Before we open it up to questions, I might just go to the results of our poll question 2. For those of you who with a diagnosis of breast cancer, what surgical treatment have you had? We're particularly looking at what treatment people are having to the axilla. So wide excision and sentinel node was 26%. Mastectomy and sentinel node 31%, so you can see there at least 50+ having sentinel nodes. Wide excision axillary clearance 3%, mastectomy axillary clearance 34%, and no surgery 6%. Now, Tony, I guess let's say patient Jane comes back from the big smoke, has had chemo, radio, maybe a year of Herceptin, lands on your doorstep. What do? You struggle to find the letters that may not have arrived, or do you...
Well, John, I think there's several important issues here. First of all, those of us who live in rural and remote areas, we have a barrier of access, obviously, and people who have breast cancer, who require regular follow-up, have been asked to travel very frequently, often large distances, to obtain that follow-up at cost and inconvenience, not only to the patient but also her family. So there's a real issue here, and I think a real opportunity for general practitioners to step up and be part of that follow-up in a shared care arrangement. And with that in mind, I'm actually chairing a group with the National Breast and Ovarian Cancer Council looking at a shared care model for women with early breast cancer. And we have a variety of specialists, oncologists, surgeons, and other people sitting around the table helping us to develop that. And we've looked at the international evidence, which shows that when GPs attend to follow-up based on best evidence, that the results are very similar. So it's safe, and it's also very acceptable to women. So I think that's two critical issues. But there's a really key principle here. We need to engage the woman and her family to make sure that they're comfortable with it. Obviously, we need to have a conversation with the various treating specialists to make sure that they're comfortable with it. And we need to ensure that GPs feel comfortable with it as well, that they have the right educational background, that they have the right tools, so templates for referral, a means for rapid access to the specialist should there be a recurrence or a new primary, for instance, found in that regular follow-up. So I think there's a real key role for general practice moving forward. And I think the recent figures that have come out of the Australian Institute of Health and Welfare around increasing numbers of women with breast cancer and of course translating into increasing survivorship really compounds the need for general practice to be part of that answer. And I think the other really crucial issue is also that the breast cancer is very important now for that woman, but as she moves on there are going to be other health issues as well. So she may have other illnesses such as diabetes or chronic kidney disease, for instance. We know that many women who survive breast cancer may well have significant psychological problems such as depression. And the GP is very well placed to treat that patient holistically and again to be working with a team of other specialists around her.
Well, thanks very much. Very important position in that woman and the family that have been affected by her disease as well.
Absolutely.
So, just some questions. Just first of all, hello to Margie Collins, who's watching us from Dubbo. We've 10 members of the breast cancer survivors, and I want to say hi. Hi, Margie. It's good to hear from you again. Our first question, James. This is from Annette. I think she's in Sydney, who says, I was 34 years old when I was diagnosed with breast cancer, had a wide local excision, chemotherapy and radiotherapy, and I was disappointed to be told because I was very thin I wasn't a good candidate for reconstruction. What upset me was the prevailing attitude that I have survived and that should be good enough for me. And believe me, I was grateful for that, but as there are ever-increasing number of survivors who live longer, it's not enough just to survive. So what do you think, James, about that?
Well, John, look, I can feel that Annette's very upset by the attitude from her treating team, presumably, and I think she's perhaps picked up on some of perhaps what I would consider sort of more traditional, old-fashioned sort of views. And I think that'd be an unusual sort of view held by most of the colleagues I work with. I think most people are very understanding of women's positions now, and I think a lot of what I've talked about and what we're going to hear later this evening is about managing ongoing symptoms. In fact, it's just the beginning of a very long journey with breast cancer. And I would like to think that most of my colleagues have probably moved past that sort of attitude, but clearly she's felt that that's happened to her. Regarding a reconstruction, she says she's too thin. I'm not quite sure what that means, and it's hard for me to comment without actually meeting her, but I think I would probably encourage her to seek a second opinion from either another breast surgeon and probably a plastic surgeon. I think.
And I guess you showed lots of pictures that are very thin women who can have an implant after radiotherapy. And
you could have after radiotherapy. Yeah, it'd be relatively few people who'd be completely contraindicated to some form of reconstruction. I say that very broadly, obviously not knowing her particular situation, but I think that'd certainly be worth seeking further opinions. I'm sure she'd be able to find someone in Sydney that perhaps has an attitude she'd feel more comfortable with.
Great, thank you. This is from Leslie, a woman in the country New South Wales. Having had breast cancer and living in a country centre, I would like to know best practice for the following. Now, Leslie talks quite a lot of issues, who should she see, monitoring, scans, but probably if I can ask Nicholas, what are the key tests you do when you see your patients in follow-up?
Okay, so remember, I'm speaking as a medical oncologist and not as a surgeon or a radiation oncologist. The key test that I perform on every patient is to say, how are you feeling? Because if the woman says, actually, I'm really pretty good, nothing new has happened to me since I last saw you, then as James said, there are things that we will do, physical examination and so on, but there's really no indication at all to do any scans, tests, blood tests, other than the yearly mammograms and ultrasounds. And it's very natural to think today, particularly with all of our technological advances, surely you should be doing some whiz-bang scan on me. But this has been looked at very carefully, and as we all know, inevitably you cause more problems than you solve. You find some little abnormality, we don't really know if it's relevant or not. Now we've got something to worry about. We didn't have anything to worry about before. Maybe we've got to do more scans or biopsies or things. And there's really no indication for scans. But if when I say, how are you, the answer is, actually, I've really had a sore back, the last few weeks, it's getting worse rather than better. Well, we all get bad backs. It probably is just a bad back, but then we should look into that. We should do some x-rays or maybe a bone scan.
Yeah, thanks. Sometimes I see patients and they think I'm a bad doctor because I'm not doing any tests, and all their friends are saying, what's this professor doing? He's not doing any tests on you. And I guess it's hard. It's a hard explanation, isn't it?
It can be a little bit difficult, yes. And it's a little bit like the person with a sore throat going to the GP and demanding antibiotics when maybe they don't need it. And
yes,
it's something that we have to sort of handle and gradually re-educate our patients about. Yeah.
And something Leslie mentioned is monitoring of tumour markers, and I guess that's a no-no these days.
Well, again, look, it's a clever idea. It makes sense. It's just that so far the technology has not got good enough to do it. And one day we probably will get good enough, but at the moment we're not good enough.
Thank you. This is from Jilly. I've suffered from neuropathy after a bilateral mastectomy 2 years ago and was informed by my initial oncologist that my symptoms were bizarre. I believe that the cohort is particularly biased to being stoic all about treatment, and so the actual statistics of those who may be affected may be skewed. because the right questions are not asked. Have you found this to be so? Now, let's just talk about neuropathy after auxiliary treatment or mastectomy or sentinel node.
Well, John, I think what I would warn my patients generally is if they're having a full auxiliary dissection, that's usually because nowadays, because their sentinel node's been involved with disease, so we know it's worth the risks of lymphedema in completing the auxiliary dissection. Certainly, when we take all the lymph nodes out as a packet under the arm, there is a nerve that traverses the lower part of the armpit called the intercostobrachial nerve. And that actually supplies a strip of skin up the side of the arm and across into the armpit. And that, by being cut, will cause a numb patch. And what I often tell women is that over a period of time that numb patch may shrink, but very rarely does it go away. I have one patient who actually swears it went away, but she's the true exception to the rule. But generally speaking, and I warn them that for about 3 or 4 months, perhaps they're going to get like a little electric shock pains running down their arm or funny weird pains, but eventually that'll settle in the vast majority of women. In fact, if I ask most women at the end of a year and I say, how's your numb patch? They look at me and go, oh, your numb patch. Like it becomes not a big issue. Now, if she's referring to that, she might be the 1% of people who doesn't really settle down. It's got something called a neuralgia, which is a painful patch rather than a numb patch. Women who have had a mastectomy will often report numbness over the chest wall and the skin flaps. And that can continue to improve for up to 3 years. But once they get up to 3 years, if they've still got a numb patch at 3 years, it'll probably always be numb. I wonder whether in her case she might have had some chemotherapy and it might have been related to Nicholas's treatment rather than mine.
Maybe Nicholas instead. Okay, Nicholas, you're getting all the blame.
No, it could be my fault. And there are some chemotherapy drugs that we use that do affect the nerves. One in particular called paclitaxel or Taxol, and that can cause some pins and needles. Again, it generally goes away, but as we know, when we damage nerves, whether it's through chemotherapy or through surgery, nerves are very, very slow to heal. So it can be frustrating. It may take months or even longer than a year, but it does get better.
Louise, do you have anything to add?
No, just that women often say that they're walking around like their arm like this and they're like a little chicken because of this numb feeling. And I guess if we try to reassure women that this is normal and that the numbness usually does settle and the shooting pains, pins and needle feeling is normal, once you reassure people that it's a normal reaction, then people can come to terms with living with it and hoping that it will reduce over time.
Okay, and I guess as a radiation doctor, very rarely you can get brachial plexopathy from radiation when you treat the neck area, but the most common thing I find, and maybe I'll get Tony to comment, is people sleeping on their side, jamming their neck and getting pins and needles, and a lot of them think they've got neck pain due to cancer or pins and needles due to cancer, but it's generally posture. Not sure if that's something you experience in general practice.
I think that's a really common problem with any cancer survivor, really. Any pain immediately brings a fear to the patient that it's a recurrence of the cancer or a metastatic spread. And so it's really important to take a detailed history, examine the patient thoroughly, and then to do an appropriate investigation. That may be an X-ray, or it may be a bone scan, or it may be reassurance and some physiotherapy, for instance, with the ability to come back if it doesn't get better, obviously.
Right. There's I think a quick question here from a general practitioner in Hunter Valley, basically talking about the fact that surgeons and oncologists are accepting smaller and smaller margins. And I guess that's one of my research areas, to say that basically we don't get too worried about margins as long as there's clearance. And there's been some very good evidence from Westmead and from Harvard Uni even showing that margins as small as less than 0.5 of a millimetre and even less than 0.1 of a millimetre has the same recurrence rate after radiotherapy. And the things that I look for, not just the margin, but what's around it, is there a lot of lymphatic vessel invasion, there's a lot of pre-cancer, what we call extensive intraductal component, and perhaps if a woman's very young, we might go back and do a re-excision. But if a margin's tight, it really, as long as it's clear, we give radiotherapy. Now, from Barbara at Baddow Bay, is it safe for women who've had lymph glands removed to do weight training? Louise?
Yes, it is. And there's been more recent research out to say that weight training is something that women can do after surgery. But again, my only proviso is that you listen to your body and you don't go and start lifting a 5 kilogram weight after you haven't lifted any weights for a year. That you start with a very small weight. perhaps even under the guidance of a physiotherapist or an expert in exercise upgrading programs, so that you can gradually upgrade the activity and listen to your body. And if you feel that both of your arms lifting the weight, you've just got general body ache and fatigue, that's normal for any of us who go and start a new exercise program. But if it's specific to the arm, then you might actually take a break, take a rest and think, reduce the weight or start a bit slower next time.
Okay, thank you. From Donna, I'm currently taking tamoxifen for ER-positive breast cancer. I've been told that certain vitamins and other herbal extracts may be estrogen producing, for example, Siberian ginseng. Is this true, and are there others that have the same effect? Nicholas, I guess?
Look, that's a good question, and we don't have a fully complete answer to that, but perhaps I can just make a few comments. Firstly, even in our normal diet, let alone herbal or vitamin supplements, there's an enormous number of chemicals there, and it's really impossible to characterise every single one. The things that I guess you hear talked about a little bit are particularly soy products and whether they may have some estrogen-like effects. It turns out when you look at it carefully that it's actually incredibly complicated to work out whether that's true or not. And I think the bottom line is that tamoxifen is there as a blocking agent, and it should block estrogen or things like estrogen from getting into any cells if there are any left in your body. So I think broadly speaking, as long as you're keeping on the tamoxifen, anything else that you take is very reasonable, as long as you're not taking absolute bucket loads of it every single day.
Okay, thanks, Nicholas. Now, there's a question on bilateral mastectomy. I guess, Judy, in your family history clinic, you must be seeing women that you have recommended bilateral mastectomy, and you mentioned that.
That's right, John. I will talk about that a little bit later, but for women who are identified to be at very high risk because they've been found to have a faulty gene, those women, some of them will choose a bilateral mastectomy with or without reconstruction in order to reduce the risk, and it certainly does reduce the risk, but it's not the choice for everyone.
Okay. And I guess there's a question from Jilly. Do you need to do an ultrasound in that setting?
Post
bilateral mastectomy?
No, we don't generally do that. I think if it's truly risk reducing and we've brought them back, I can quote a 98% risk reduction, relative risk of what they were going to have of breast cancer, that in fact we don't screen those women now, but if they become symptomatic, obviously we need to investigate them.
Okay, and last question from Rebecca. I'm 34 with a triple negative breast cancer and have had a mastectomy. Will having radiation affect the viability of having a reconstruction?
Look, I think it does influence our choice of reconstruction in that we know that a two-stage artificial reconstruction, which I showed a lot of examples of, we get the best results in women who haven't had radiation treatment. But that's not to say it couldn't be done. Generally speaking, most plastic surgeons in that setting will probably recommend some sort of tissue flap reconstruction, whether it be borrowing the skin, fat and muscle from their tummy or from their back. Or sometimes it may be a combination. We may actually put a small implant under the muscle and the skin, which may not stretch up as much because of the radiation, and we'll maybe perhaps bring some tissue around from the back to cover it, and that'll give a total volume which is acceptable and a more natural feel. So it certainly doesn't preclude reconstruction altogether.
Thanks, James. And I guess that's one of the reasons perhaps at Westmead we're recommending more immediate reconstructions, because you can then avoid that. You can stretch your skin before you give radiation.
Yes, certainly if you know you're going to go ahead and have an artificial reconstruction, I think it's preferable to do that at the time of the mastectomy, have it inflated while they're having the chemotherapy, and then the radiation given while the implant is fully stretched, rather than the other way around. That is, doing it after the radiation. But that doesn't it's not an absolute rule, but certainly that's our preference. And I think we get better results. We've
seen many women who've been able to. The muscle and the skin is still able to stretch after radiotherapy. Well. Earlier is better than later, of course. The longer time you leave it. Now, poll question number 3. For those of you who have had a mastectomy, have you had a reconstruction? No, an immediate reconstruction, or a delayed reconstruction? If you could answer that question for us. I'd now like to introduce our third speaker, Dr. Nicholas Wilkin, to tell us about his top 3 questions.
Thanks, John. And as we discussed before, I thought what I'd do is talk about this whole 5-year landmark. And I've also got people, a lot of women asking me now about this so-called replacement for tamoxifen. So we'll talk a little bit about that, and all of us have touched on the issue of diet and weight and so on, and I might make just a couple of comments about that. So many of you, I know, will have had your doctors or your friends and family and relatives talking to you about 5 years, and we've got into the habit of talking about 5 years as some kind of particularly special point. And I know that it sometimes causes some confusion for women, not sure what to make of that. Does that mean that if I get to 5 years and nothing's happened, then I can forget about treatments and scans and things and it's all fixed? Or does it mean that my doctors are going to abandon me after 5 years? What does it all mean? And I think just to put that in perspective and explain it to you, it's worth just giving you at least my version of why we ended up talking about 5 years. And the first reason is that, of course, if you get to 5 years after your diagnosis of breast cancer and nothing bad's happened to you, that's fantastic. So we always look forward to seeing our patients getting to 5 years. Secondly, in the early days when we were doing the kind of research that's really paid off, that told us that giving tamoxifen for women with hormone receptor positive tumours was a good idea, or to give some women chemotherapy. The initial studies looked at how long to give tamoxifen for, and it turned out that, at the time anyway, the answer seemed to be to give for 5 years. It was a little uncertain whether giving it for longer than 5 years was a good idea, and it was known that giving it for less than 5 years wasn't as good as giving it for 5 years. So we again started to talk about this 5-year mark as something special. And lastly, when we did the chemotherapy studies, our general impression was that obviously getting to 5 years is a very good thing. So we tended to do these studies and report the results after 5 years of follow-up and show whether chemotherapy A was better than chemotherapy B or chemotherapy was working and so on. And we didn't really pay perhaps as much attention as we should to time after 5 years. And also these trials are big, international, complicated, expensive. So often we didn't actually follow the women for longer. So for those reasons we started talking about 5 years, and 5 years is an important point to get to, but you can see from what I've said that it's not that different from 4 years or 6 years, and had we been doing slightly different studies, we might have ended up talking about the magical 6 years or the magical 7 years rather than the magical 5 years. So what does that actually mean when you do get to 5 years? Does it mean that you're cured? Does it mean that you stop treatment? Or what does it mean? I think the first thing it means is that you should congratulate yourself that you've got there, that it's a fantastic place to be 5 years down the track and no signs of any breast cancer recurrence. You also should know that although it's extremely unlikely, it certainly is possible that your breast cancer could come back. So even though you probably don't really need to be seeing specialists at this point, we would still strongly recommend that you keep having mammograms once a year and seeing at least the local doctor, and you might have a particular relationship with the specialist and continue to see that specialist, but that's not absolutely necessary. And lastly, there are some situations now in women who have hormone receptor positive cancers where we do recommend that it's worth thinking about having treatment for a little bit longer with one of these new tamoxifen tablets. So it's certainly, if you're taking tamoxifen or one of the so-called new tamoxifen tablets, you should at 5 years talk to your doctor about whether that should stop or continue. So the graphic I've got up there is to tell you about these so-called new tamoxifen tablets. They're called aromatase inhibitors, and as I put up there at the top, a very, very important point, these tumours, these treatments are only effective in women who have gone past the menopause. So if you're still young enough to be premenopausal, you shouldn't be taking these tablets. Now there are 3 of them, and I know it gets a little complicated because drugs tend to have have a drug name and a brand name. I've listed the 3 of them there. So there's anastrozole, which is also called Arimidex, and exemestane, which is also called Aromacin, and letrozole, which is also called Femara. And essentially these 3 drugs have all been carefully tested, and they've been shown to work, and they've been shown to work to roughly the same extent. So there aren't really significant differences between these 3 drugs. Now, why might we consider using these drugs called aromatase inhibitors instead of tamoxifen? And I've listed there in the graphic, you can see it's a little bit of a weighing up of pros and cons. So firstly, the studies that have been done have shown that these drugs are slightly better. It's not a big difference, it's just a small difference, but slightly better than tamoxifen at stopping breast cancer recurrence. On the other hand, they're actually slightly worse for your bones. They have a mild bone thinning effect, whereas tamoxifen tends to be quite good for bones and tends to have a more building up effect on the bones. On the other hand, again, tamoxifen very rarely, about 1 in 1,000 cases per year, but very rarely can cause endometrial cancer or blood clots, and these new drugs don't do that. But again, tamoxifen generally doesn't cause any problems with joint aches and pains, whereas these new drugs do. So you can see that it's not absolutely clear-cut if you're past the menopause and if you have a hormone receptor positive cancer that you necessarily should be on these new aromatase inhibitors, but it is something that you should ask your doctor about. And lastly, I do have a lot of women after the initial fairly hectic treatment phase of their breast cancer, where they're having surgery, perhaps radiotherapy, and perhaps 3 to 6 months of chemotherapy, and then perhaps they're starting on tamoxifen or one of the aromatase inhibitors. I've gained weight. I've put on 5 or even 10 kilos. Why is that? And the short and kind of facetious answer to that is because you eat too much and you don't do enough exercise. That applies, of course, to all of us. But it turns out that if you've had these kind of treatments for your breast cancer, that we doctors have actually been part of the problem. And in fact, for complicated reasons that we don't fully understand, women having chemotherapy for breast cancer often have a tendency to put on weight. And in addition, chemotherapy in premenopausal women causes a lot of potential hormonal upsets and can bring on an early menopause, and that can sometimes involve weight gain. And then it doesn't actually happen as often as people think, but some of the hormone blocking drugs like tamoxifen and the aromatase inhibitors can cause a little bit of weight gain as well. So if you have put on weight through your breast cancer treatment, number one, that's not unusual. Number two, it is partly our fault. But number three, unfortunately, the answer is the same as it is for all of us if we put on weight, and that means that we have to watch diet and work on exercise. And as you've already heard from Louise and James, there are other very good reasons why exercise is good for you from a general health point of view, but also from a breast cancer point of view. John.
Thank you very much, Nicholas. We've just got the results of our poll question 3, which was, for those of you who have had a mastectomy, have you had a reconstruction? No in 60%, immediate reconstruction in 20%, and delayed reconstruction 20%. Those figures are very, very interesting, James.
I think they're probably quite good overall, because it suggests that 40% of the women who've had a mastectomy have had a reconstruction, and I think the national average probably runs around about 12-15%. So that's obviously the women out there listening are probably from a more educated group, I think, or a group of people who've been offered, really current modern treatment. So.
Okay, we'll go to our 4th poll question, thank you. What endocrine therapy, that is hormonal treatment, have you had? No hormonal treatment, tamoxifen, an aromatase inhibitor, removal of the ovaries, or various combinations of the above. And just now I'd like to introduce our final speaker, Professor Judy Kirk. Tell us about your top 3 questions.
Well, John, the first thing I'm going to talk about tonight is that question when a woman's diagnosed with breast cancer. Now that I've been diagnosed, does this change the risk for my sister or for my daughters? And that depends on 2 things, really. It depends on the age at which you were diagnosed, so that we know that breast cancer is common, especially over the age of 50, and it's very common to have one or even several family members diagnosed with breast cancer at that age. And in a general way, having just one relative with breast cancer diagnosed at an older age really doesn't make a difference to risk for the other family members. However, sometimes there are additional family members affected. Now, perhaps there are a couple of older family members that might mean a moderate risk to the unaffected women in the family, but occasionally there are women with a genetic predisposition, and we're going to talk about that next. Remember that most women who develop breast cancer actually don't have a family history of breast cancer, but there are some families who do have a genetic tendency to the disease, and they have some quite special features. There tend to be a number of affected family members in different generations with breast or sometimes ovarian cancer. That's a related cancer in these families. And there might be other features. There might be cancers at a younger age than we would normally see. Perhaps a woman with several cancers, perhaps cancer in both breasts or cancer of the breast and of the ovary. There may be sometimes men with breast cancer in those families, and they're more common in families with a Jewish background because of certain specific mutations that evolved many years ago which cause a high risk of breast cancer. So it's only in these very special families that we consider genetic testing. In other words, genetic testing is not for everyone. It tends to be for the people with a stronger family history. And I'm going to talk a little bit about genetic testing and what we do, because essentially we try to develop a genetic test that will help to clarify the risk for other women in the family who are worried about breast cancer. The first thing we do in those families is what's called a mutation search. So we're looking for a fault in a gene that causes the problem. And I'm going to show you a picture of the genetic material, firstly to show you that the genetic material comes in pairs. So for each of these chromosomes that we can see down the microscope, one's from mum and one's from dad. But in there are about 30,000 different genes, and I'm only going to talk about 2 of them tonight. One of them sits on chromosome 17 and it's called BRCA1, the breast cancer 1 gene. The other is BRCA2. Now these are normal genes, we've all got them, males and females, and they're cancer protection genes. The problem is that some people start off life with one faulty copy of one of these genes, and those are the people at higher risk. So when we do genetic testing, we're looking for a mistake or a mutation in one of these normal genes. The first thing we do is we take blood from an affected family member. So when we're looking for a gene fault that's causing a problem, we first take blood from somebody with the problem, and that's called a mutation search. That takes us quite a long time, and in many families we can't yet locate the fault that's causing the problem for that particular family. We don't know everything there is to know about this, and there may be other breast cancer genes that are identified in the future, and we can test them then. But for now, many families are tested and no causative gene mutation can be identified. But for some people in the family, or for some families, we can actually very clearly identify the fault in the gene that's causing the problem for that family, and then we can go ahead and do testing for other family members, and that can be done very quickly and accurately. So it can tell a woman whether she's got the gene fault that causes this very high risk or whether she doesn't have the gene fault in BRCA1 or BRCA2 that's causing the problem for her family. That's good news, because if you don't carry the family gene fault, you're at the average risk and you can't pass the gene fault on to your children if you don't have it yourself. And that leads us to the very important question, what do we do with these women who are identified at very high risk because they carry a faulty gene? Well, the first thing we do is very careful screening, often from a younger age than we would normally start. And for older women, that can be done with mammogram and ultrasound. But for younger women, we're introducing MRI as a very sensitive screening tool, not freely available yet, but certainly will come into play over the next couple of years. The other thing is that there are certain chemo prevention options. So the drugs that we use to treat breast cancer, drugs like tamoxifen and raloxifene, have been shown to reduce the risk of breast cancer in women who've so far not been affected by the disease but have a strong family history. Some of those drugs have side effects, so we have to give careful consideration as to whether they should be given for prevention. And we don't really know in women, for example, with a BRCA1 mutation, whether they'll be effective. And finally, women may choose to have risk-reducing surgery. We mentioned before that bilateral mastectomy, removal of all of the breast tissue with or without reconstruction, can be a very good option for people who are found to be at very high risk because of a genetic fault. Certainly reduces the risk of breast cancer for those women. But also these women are at increased risk of cancer of the ovary and fallopian tube. That's a difficult cancer to find and a difficult cancer to treat. And for that very reason, one of our priorities in these very high-risk women is to remove the ovaries and fallopian tubes after they've finished having their families. And we know we can do that. Not only does it reduce the risk of ovarian cancer, but also halves the risk of breast cancer in those women. So a very important and simple thing that can be done after a woman's had her family. We can give her a little hormone replacement therapy after that, and we know that it reduces the risk of both cancers. So there are important things that can be done. A lot of research is still ongoing in that area. So finally, if you're somebody who's concerned about your family history, the very first thing you should do is talk to your general practitioner. Your general practitioner will help to be able to assess the family history and determine whether you should be referred to a family cancer clinic to think about genetic testing for your family. Thank you, John.
Thank you very much, Judy. Just let's go to the results of our poll question number 4. What endocrine therapy have you had? No endocrine therapy, 43%, tamoxifen, 31%, aromatase inhibitors, 9%, and removal of the ovaries, 0, combinations, 17%. So thank you to everybody who answered that poll question. So we're now back to question time, and I'd just like to perhaps kick off asking Judy, if someone has a strong family history of breast cancer, mum, grandmum had breast cancer, had the genetic test and it's come back with a BRCA1 mutation, when do you recommend, what age should they have removal of the ovary and the fallopian tube?
Well, if someone's been identified as having a gene fault in BRCA1 or BRCA2 that causes a very high risk of breast and ovarian cancer, one of the best things we can do is to remove the ovaries and fallopian tubes after a woman has finished her family, and possibly around the age of about 40. We know that the ovarian cancer risk starts to pick up at about that time, and also we know that if we remove the ovaries before the menopause, we get the best chance at also reducing the risk of breast cancer. Now that would render the woman through the menopause, and for those young women who haven't had breast cancer, we feel it's quite safe to give a small amount of hormone replacement therapy to keep the rest of the body healthy until about the age of 50. So it can be safely done.
Okay, and James, you've done this type of surgery. What's the key, what can you say about it?
Look, I think nowadays, John, for most women who haven't had a lot of a previous abdominal surgery, we can do this so-called laparoscopically or through keyhole type surgery, and it's very safely performed that way. We aim to take all the ovarian tissue and along with the fallopian tube. We often just maybe leave a little tiny cuff at the edge of the uterus, but in fact all the tissue is removed. That's a very successful operation. Can sometimes be done as a day surgery or just a simple overnight stay surgery.
Okay, and Nicholas, coping with hot flushes and side effects after that?
Hot flushes, as many of you know, can be a huge problem. So perhaps if we can just divide it up into, if the woman has gone through menopause because of this genetic background and she's had the ovaries removed, then as we've said, cautious low dose of hormone replacement therapy up to the age of 50 is safe, and that should stop hot flushes. But as you know, a lot of women that we treat for breast cancer will develop a premature menopause because of the effects of chemotherapy, and that's sometimes actually good for the breast cancer. It's good treatment for the breast cancer, but does end up causing a lot of hot flushes. And it is a tricky problem because we all know that the thing that would fix it the best would be a big dose of estrogen, and that's exactly the opposite of what we're trying to do. So there are some non-hormonal methods that we can employ. I mean, firstly, waiting, because it does tend to settle over time, and perhaps some lifestyle changes, alcohol, coffee, various things that may exacerbate hot flushes. There are some kind of inverted commas natural medications that sometimes can help, that you can get from your health food store, like soy products and black cohosh. To be honest, they don't tend to work that well. There are some studies showing that vitamin E tablets can sometimes be effective. And lastly, if the hot flushes are a real problem and they're really causing a lot of problems for the woman day to day, then there are some antidepressant drugs that you use in very low doses, lower than you would if you were treating depression, and there are studies that show that they can be effective. That's something that needs to be carefully discussed with your GP or your cancer specialist, because there can sometimes be some interactions between these medications and tamoxifen if the woman's taking tamoxifen, so it's a little complicated. But I guess the short answer is we need to avoid HRT as much as possible. We would expect the hot flushes chances to gradually get better over time, and there are some things that we can do to help. But we all recognise that even given those three things, it sometimes is a problem.
Tony, do you have any comments about that?
Look, it's a common problem, I think, hot flushes, and also, of course, vaginal dryness and dyspareunia or difficulty during intercourse. So either topical estrogen is one possibility. And again, that's a conversation that I would have possibly with the treating oncologist to see whether they felt that was an appropriate thing to do. But certainly I have patients who are taking venlafaxine, for instance, for hot flushes in small doses, which seems to work really quite well for that particular symptom. But again, you would do that in consultation with the treating oncologist to make sure that they were comfortable with that, and of course keeping the patient very much at the centre of that care as well.
Okay, and that's Effexor, isn't it? Is that,
yes.
That's right. So, and that's something you do, Nicholas, as well?
Yeah, but I think, again, we want to try and avoid making life too complicated, so we don't always want the answer for the problems that one pill's caused to be another pill. But there are some situations, as Tony said, where hot flushes are a real problem. You've tried the other things, they haven't gone away, and Effexor or venlafaxine can be very effective.
I know we had Dr. Michael Kreichman, who's an expert in sexology from California at our Lura conference last year, and he's got a couple of new books out, and he really strongly recommends vaginal moisturisation and lubrication. So water-based lubricants prior to sex, but daily moisturisation with vitamin E cream in the vulva and introitus as well. So not only your arm but also vaginal area can help. And vaginal estrogen, I certainly give, but I know at a menopause conference I went to this year, there's some caution in women with aromatase inhibitors, but we think it's probably okay in women who are on tamoxifen. So that's my policy. There's probably no right answer.
No, I think the topical estrogen story is, I mean, you're right, it's controversial. We're not quite sure. We don't leap into it. But I think it's like so many things that we do in medicine, it depends how much of a problem there is. And if there's a real problem and major discomfort, it's having big problems in the relationship, then I think cautious use of topical estrogen is a good idea.
All right, I want to get through some questions quickly, so we'll try and have some short answers to some of these. Some of these are fairly quick. From Gerda, you mentioned having a bone scan. Why might you do a bone scan? Nicholas?
So we just need to be careful here about, because I think what Gerda, what you're referring to is, James was talking about a bone density scan. So there's two kinds of bone scan we can do. One is to check how thin or thick your bones are. In other words, are there any signs of early osteoporosis? And the other is a bone scan, which is looking for whether there might be some cancer recurrence in the bones. So as we talked about before, if you're well and don't have any significant new aches or pains, we wouldn't be doing a bone scan looking for any cancer deposits because we wouldn't expect to find them. But if we've perhaps caused an early menopause or you're on one of the aromatase inhibitors, then we think it's prudent to check the bone density, maybe not every year, every 2 or every 3 years, something like that. So that would be why we would do a bone density scan.
Okay. Now, Michael King, I think that must be North Coast Area Health Service. The Arimidex is currently recommended for 5 years. Is that likely to be extended?
We don't know yet. The thing that we most know is that if the first drug that you were given was in fact tamoxifen and you had 5 years of tamoxifen, there may be some extra benefits from going on to Arimidex or one, as I said, there's 3 of them, to one of those drugs beyond 5 years. If you started out with Arimidex or one of the aromatase inhibitors, we actually don't know yet. We don't have any clinical trials. We get this sense that if you started out with a bigger cancer or a number of lymph nodes involved, that maybe longer than 5 years is a good idea. And just to give you an example of how we make these decisions when we don't have the clinical trials, James and I actually had a telephone conversation about this exact problem. I think it was yesterday, was it? Or whenever.
I read last month on the same thing.
And we agreed that in that particular case, probably longer than 5 years treatment would be a good idea, but we didn't know the full answer, and we decided that we would do that, but we would review that decision each year.
Yeah. I mean, I think there's at least 2 trials trying to address this right now in terms of the duration of Arimidex and so on. Now, this is from Penny Briggs. Hi, Penny, breast care nurse in Western Australia. I have a client ask me, does reconstructive or augmentation surgery make it more difficult to detect further breast cancers?
Look, it's a commonly asked question, and I think the bottom line is if women remain familiar with their breasts and have, certainly after breast reconstruction, if it's used in the setting of mastectomy, with an artificial reconstruction, often I think detection of a recurrence is actually easier because the skin and the muscles now stretched up quite thinly, and that means that any clinical abnormality in the skin will become apparent quite easily. In the setting where you've had a tissue flap reconstruction done, I think sometimes it's possible recurrence could be hidden or masked underneath that, but that would be pretty uncommon. So I don't generally worry, for most women, that a reconstruction would delay a recurrent diagnosis. In the setting of breast augmentation, I think it's one of the questions frequently asked, and women are worried about it. There is no evidence to date that it impacts on the overall survival. Certainly you can do Eklund or pushback views with the mammography, so they actually end up having more mammograms, but you can actually get most areas of the breast on. And most of these women have had small breasts to start with and maybe dense, so they'll often have an ultrasound as well. So I think you can get around it. It certainly wouldn't put me off recommending a reconstruction or talking a woman out of an augmentation. Yeah,
I think certainly in my practice, past 25 years, I've never ever seen a recurrence hidden by a reconstruction. If it does recur, it tends to occur on the edge because that's the skin that's left behind from the chest wall if you have a tram flap. But
or in the scar.
In the scar, basically, as or on the skin. So I don't think that should ever be a reason for delaying. And certainly, if there's any symptoms, we can actually get under that reconstruction with MRI scan or ultrasound or CAT scan even. I don't want to spend too long on HRT because I know it's a session on itself, but there is a good question here from Barbara from Braddow Bay. Is it safe for women with an estrogen receptor negative tumour to take HRT?
I think the short answer is probably not. That's the shortest answer. It's probably likely to be not as much of a problem as if you had an estrogen receptor positive tumour. But I think, to be honest, unless it's done very, very carefully and you've got really, really crippling menopausal symptoms, any diagnosis of breast cancer would mean you'd really want to be pretty reluctant.
Yeah. I must say I'm a little bit more relaxed to ER-negative tumours, again based on not a lot of data. The recent, now was it the Liberate or the Habit study? I think it was a Habit study, basically showed that women who took Livial, which is Tibolone, after breast cancer, did in fact have a higher risk of breast cancer coming back. And that was a disappointment for all of us who start off with Effexor or Provera or whatever, and then we go on to Livial and found that even, in fact, distant recurrence was higher. But when you do read the fine print of that paper and look at the recurrence rates and the hazards and everything, I was reassured a little bit that the ER-negative tumours, the confidence intervals at least crossed, and so proceed with care, I think, is
I think it's one of those things you would not make a policy statement about it. Just a case-by-case sort of discussion, but you want to be extremely cautious.
Now, I feel we're picking on Nicholas a lot here.
Ask Judy a question.
But there's Leslie in country New South Wales. Is it wise to have follow-up echoes of the heart after chemotherapy, and if so, for how long?
Well, good question. Perhaps we can just go back a step and say that there is one chemotherapy drug that we use that's very helpful, has saved lots of lives, but has a low, probably less than 1% risk of causing some heart damage. And then, as many of you know, there's a new antibody treatment called trastuzumab or Herceptin, and that also has a low, maybe a 1 or 2% or something like that, risk of causing heart damage. So I'll tell you what we do in practice. What we do in practice is we do a heart scan, whether it's an echo or a nuclear scan or something, before we start any of these treatments to make sure that there aren't any unknown heart problems. And then, particularly with Herceptin, we would then do that every 3 months. But we don't generally do it once the treatment's finished. Partly that's because in the Herceptin trials, it seemed that if you're going to have a heart problem, you have it straight away while you're on the Herceptin, and once the Herceptin stopped, the problem goes away. And secondly, if the reason that we're looking at the heart is because of this chemotherapy drug, the overall risk of heart problems really does seem to be pretty low. So we wouldn't advocate routinely doing it after the treatment finishes.
Okay, thank you. Look, there's a couple of questions. It's Anne, and there was somebody else in that pile, but which is, what's the probability of dying from breast cancer 10, 15, 20 years out? And maybe I'll just answer that really quickly. I did a calculation once using a very long-term follow-up study from the United States, and we found that if you get to 10 years, there's a 95% chance of getting to 20 years free of breast cancer, once you get to 20 years, it's like 99.9%. So the reality is, as Nicholas said, once you get to 5 years, most of the recurrences have appeared, and it's really important not to get focused on the statistic, but try and get back to life and the important things of life, I guess. And I'm not sure, Tony, if you've got any thoughts, because you treat a broad spectrum of disease. How do you get people focused on family, gardening, I don't know, to get away from this sort of constant fear of disease?
Well, I think it's a real challenge, but I think, you know, you're looking at a whole person here in front of you, and in the context of her family perhaps and her local community. And as Louise said, it is really about engaging in a very positive way with that particular woman, telling her that she's got a very good chance of cure. And again, that was reinforced in the latest Australian Institute of Health and Welfare report, that cure and survival rate at 5 years is increasing. So I think the message should be positive, but with appropriate follow-up, ongoing. And I think that's the realities, and that's probably the best we can do to support that woman, by being positive, but making sure that we're having appropriate follow-up according to best evidence.
Okay, we've got time for one more question. There's a couple of good questions here. I might just take Rebecca's question. Can you please talk to us about triple-negative breast cancer? And I feel like chemotherapy treatment for this type of cancer is a bit of hidden hope. There doesn't seem to be much information out there for triple-negative breast cancer, which is estrogen receptor negative, progesterone receptor negative, and HER2 negative breast cancer. So less treatment options. Nicholas, is there a quick answer?
Yeah, I think there are a few answers. Firstly, it's not true that these tumours are not sensitive to chemotherapy. They are sensitive to chemotherapy. It's just that whereas with the other cancers we've found some specific treatments, we're still working on that with triple-negative breast cancer, but there have been some very interesting studies reported this year in the States, and studies going on next year. And it may be that we're about to find a target that we can actually latch onto and use both chemotherapy and the targeted treatment. And my prediction is that within 5 years we'll be doing that.
Thank you. And thank you for everybody for all these questions. Believe it or not, we've got through most of them tonight. But I just want to come back to our panel and see if you can give us some take-home messages, starting from Judy.
Well, the take-home message from me would be that family history is common because breast cancer, unfortunately, is common, especially over the age of 50. So not all family history will change risk. But for some families with a very strong family history, genetic testing can help find the cause and identify the women who are at risk and those who are not at risk in the family, and that we have very good screening and prevention options now for those women who are identified to be at high risk.
Thank you. Nicholas.
John, my take-home message would be that once you get to 5 years, you should be congratulated. That's fantastic. You've done well. The chances of the cancer coming back at that point are low, but don't stop having your mammograms every year, and make sure that you keep in touch with your general practitioner.
Thank you. Tony.
That's a really nice segue for me, really, isn't it? The important role of the general practitioner here as the longitudinal carer with this particular woman, looking after not only her breast cancer but also her other health issues and her survivorship moving forward in a very positive way, and making sure that we keep her as a very central part of the team in a true partnership, and making sure that we communicate well with the other treating specialists.
Thank you. James.
I really echo what's been said, John, to say that I think follow-up is an important part of their longer journey. They should stay in touch with their treating team. And for those women who have had a mastectomy and are interested in reconstruction, they should really get in touch back with probably initially their breast surgeon, who will refer them on to a plastic surgeon probably for expert advice on what they can do to try to create a good-looking breast mound.
Thank you. Louise.
I guess for me, my take-home message tonight is that it's really important for every woman to feel in control and empowered to move forward and live life to the fullest after this treatment. And I guess developing a new normal, exercising regularly, listen to your body, and with the support of family, friends and your medical team, there is life after breast cancer.
Thank you, Louise. I think that's a very important message, that there is life after breast cancer. I hope you have enjoyed the program tonight, Breast Cancer Challenges After Treatment. If you're interested in obtaining more information about the issues raised in this program, there are a number of resources available on the Rural Health Education Foundation website at www.rhef.com.au. And don't forget, if you're a general practitioner, to obtain CPD points, please complete and send in your evaluation forms. I'm John Boyages, and good night.